So thank you very much for the invitation. And I must say it was quite a challenge because, as you say, so many things are not known yet. So what I would like to do is to give you some food for thought and give you some pieces of evidence which we could use to have a kind of risk-based advice to our travelers and traveling into the COVID-19 era. And initially we were discussing whether we should focus on immunosuppressed travelers, but I think the vulnerable traveler actually for COVID-19 is much broader, and therefore I will shift my focus a bit and will not discuss immunosuppression by itself. So for this presentation, I do not have any conflicts of interest that have any effect on the presentation. And I would like to take you back to December 2019. This is Wuhan, and it's morning, it's fresh and cold, and people actually waking up, fully unaware of the crisis unfolding. Because of that moment, there were several cases of severe acute respiratory infection in a number of young adults, and it seemed to be associated with a food market. When we fast forward April 2021, we have arrived in India, where they are experiencing the second wave of COVID-19 with a collapsing health system and family members struggling to get oxygen for their ill relatives. And at that moment, we have now about 166 million cases worldwide, with over 3.4 million deaths being registered. COVID-19 has ruthlessly exposed the flaws in the fabric of our society, but it also has shown some victories. Never before we have succeeded in sequencing the genome and having a diagnostic tool available that rapidly. Between December 2019 and the 7th of January, where the genome was known, and maybe 8 days later, we had a running PCR, which we could use for diagnostics. But also the speed at which a vaccine was developed, and mid-December, the first mRNA-based vaccine was transported, as you can see here, at the US. It was shipped to the US for vaccination, and vaccination was started in December 2020 in the US. So for this presentation, I would like to discuss with you several topics which you could use to have a kind of framework for ordering your thoughts and in the advice you're trying to make to the traveler. First of all, we will discuss the most important risk factor for severe COVID. We do see incident cases of SARS-CoV-2 after vaccination. Neutralizing antibodies are the best proxy for protection, and waning of the antibodies may be more rapidly at the old age. There is a problem of variants of concern, which affects the efficacy of our vaccine strategies. And finally, I would like to give you some framework for the travel advice of the older traveler in the era of COVID-19. Because actually, the most important risk factor for severe COVID-19 is old age, and actually it already starts, I'm sorry to say, from the age of 60. Old age, in older patients with COVID-19, approximately half have severe infection, and then we're talking about 70 plus. 1 in 5 are critically ill, and 1 in 10 will die. Of course, there are other risk factors like obesity, cardiovascular morbidity, but also belonging to an ethnic minority is a risk factor for more severe cause of COVID-19. But age remains the most important factor. And in fact, the traveler that was supposed to be a 60 plus without any specific comorbidity now runs a risk of getting severe COVID when traveling to an area where he is not protected by a vaccine. So for this reason, the UK was one of the first countries that started with a mass rollout of mRNA vaccine and a adenovector-based, platform-based vaccine with the first vaccine or the first dose first in those who were most vulnerable. As you can see here on the left-hand side, the blue line, this is the interim results from the vaccination rollout in Scotland, where you see the people of 80 and older have been vaccinated already starting from December 15. And on the right-hand side, you can see the number of hospital admissions, which have clearly declined, especially in this age group. And that's what we see in the Netherlands in the same way, somewhat later. But at the moment, we admit to our hospital mainly people around the age of 60, and we don't see people of 80 plus anymore. However, there are still incident cases of SARS-CoV-2 infection, and this is a study performed on the nursing home residents, looking at the occurrence of symptomatic and asymptomatic SARS-CoV infection after the first dose and after the second dose. And as you can see, early after vaccination, there were still some cases of symptomatic SARS-CoV infection, but later on, it was mainly asymptomatic infection that was reported. You can also see that the unvaccinated residents, also the number of cases decreased, probably because of the effect of herd immunity in this community of nursing home residents. If you look into more detail, then you see that after the first dose, most cases occur within the first 3 weeks. And as you can see as well, that most cases are actually asymptomatic. But after the second dose, the number of symptomatic cases further decrease, which means that that vaccination specifically protects against symptomatic disease, but it's still possible to have an asymptomatic disease or asymptomatic infection with the possibility of transmitting the virus to an unprotected person. This may have also influence when you are vaccinated and traveling to an area, you might pick up a new strain, have an asymptomatic infection upon recurrence into your home country. And in this way, traveling might actually, under-vaccinated individuals might actually, again, amplify the amount of spread of variants all over the world. It must be said that there are indications that, especially for mRNA vaccine, but also for the adenovector platform vaccines, that the level of viral shedding is at a lower level, so there's less virus present, and also that the duration might be shorter. So the period of being able to transmit the virus may be less. Very recently, a paper came out that looked into more detail to the neutralizing antibodies. And in this paper, it's shown that neutralizing antibodies are indeed highly predictive of the immune protection from symptomatic SARS-CoV-2. There are many studies in phase 1 and phase 2, and also the large phase 3 studies that have looked at neutralizing antibodies. The problem is that each of those studies use a different assay to determine the neutralizing antibody titers. But they use also as a reference convalescent serum. And so what the authors did was that they normalized the neutralizing antibodies of a study with the mean value of the convalescent serum. So it's normalized for each of the convalescent sera. And so you end up with a mean neutralization level, which is the fold of convalescent serum, the amount of neutralization you see in a convalescent serum. So for example, if the convalescent serum has a neutralization mean activity of 1, the vaccine may be 8-fold higher level of antibody. So you can actually use the convalescent serum as a kind of marker to look at what amount of antibodies are produced, higher or lower. So on the left-hand side of this graph, you can see on the x-axis the mean neutralization level. So that's fold of the convalescent serum level. And some of the vaccines have 4 to 8 times higher levels of neutralizing antibodies. And on the y-axis, the percentage of efficacy of protection against symptomatic SARS-CoV infection. And you can see that there's a non-linear correlation between the neutralization levels and protective efficacy, which with levels of about, let's say, between 2 and 4, to get up to 95 to 97% protection. And for a 50% protection, you have about 20% of the mean neutralization level of convalescent serum. Now, if you look how well this predicts the protection, you can take out one study and then recalculate and then check for that study how it would project on the graph between the observed efficacy in the study and the predicted efficacy using this neutralizing antibody levels, which are standardized or normalized against the convalescent serum. And this is shown in the middle graph, where you can see that it is quite a nice linear correlation. So this looks as if it's highly effective in predicting the efficacy of a vaccine if you have a certain level of antibodies. And finally, as has said before, for a 50% protection against the symptomatic SARS-CoV-2 infection, you would need about 20% of the mean neutralization level of fold convalescent serum. And these, this figure shows you the different vaccines and how the distribution is of the antibody levels. And you can see there are some differences with the mRNA vaccines being on the higher level of neutralizing antibody titers and the CoronaVac at a lower level of antibody titers. After vaccination, antibody titers will rise up to a certain level, and already from the age of 55 up to, or 56 to 70, the mean the GMT titers of neutralizing antibodies are lower compared to the younger age group. So already from the age of 55, the antibody levels are lower. And for the age of 70 and older, this is even more pronounced. And also, if you look at this graph, there's a suggestion that in the older age group of 70 plus, the waning of antibodies may be a little bit faster than in the younger age group. The good news is that antibodies persist throughout 6 months after the second dose. And the problem is that while we are going on, most of the people are now being vaccinated. So it will be very hard to have any information on, let's say, 1 year or 2 years after vaccination antibody persistence, because in the studies, many people receive booster vaccinations. And so the follow-up of these studies will become a problem. If you compare that to the receptor binding, which is an ELISA, which just measures the binding of the assay, then you see that the difference is not that much pronounced. So what I don't know, is that there's a possibility that all the people are making antibodies or producing antibodies that bind well, but are less effective in neutralizing. That needs to be determined. So what does that mean, the waning of the antibody levels? What does that mean in measure of protection? Again, if you look at protection against any SARS-CoV, symptomatic SARS-CoV infection, if you start and look at the left-hand side of this figure, and you start with initial efficacy on the y-axis of 90%, and you move to the in time, you will see that it will take about 250 days before the efficacy drops to 70%. If you already had started at 70%, then it would take about 150 days to drop to a 50% efficacy in protection to any symptomatic infection. Vaccination also protects against severe infection, and there the level, the protection of severe infection actually stays on much longer, provided it is against the same strain. And that's shown on the right-hand side. So if your initial efficacy against any symptomatic infection would be dropped to 50%, you would still have a efficacy against severe infection up to 80%. And that is because the level of antibodies required to prevent severe 50% of severe infections is about 3% of the folding of the convalescent serum. So protection against severe infection seems to last longer than protection against any infection, and provided that it's still against the same strain. And there we are confronted with a problem, because this is coronavirus, as you know, has a spike protein. And just for comparison, we have the human coronavirus NL63, which is a common cold virus, which binds to the ACE2 receptor, as does the SARS-CoV-2 virus. But both are belonging to a different genus, and they only share 30% homology in their the genome that encodes for the spike protein. That means that coronaviruses have a broad potential to tolerate changes both in sequence and structure of the spike protein without substantial loss of function. It's only 30% homology means that you have 70% difference, and still they bind to the same receptor. Fortunately, coronaviruses have a proof reading on their replication, but still every 11 days you have a new mutant arising after viral replication. So in an individual who is infected, after 11 days, you will have a number of mutants that have risen from the primary infection. And because millions of people are infected at a moment, you have a lot of mutants that actually are spreading worldwide. And this drives evolution towards adaptation to the ACE2 receptor, better binding, but also to variants that actually escape the immunity that's been building up of the human population. And this is a little bit shown in the genomic epidemiology of this virus, as shown on the right-hand side, where you can see the occurrence of new clusters, and you can recognize them very well. The B117, which started somewhere in Kent, and it's created a complete new line, but also the B1315, which is from South Africa, the P1 from Brazil, and the B1617, which is from India. So these variants of concern have two major changes. On the one hand, they have a better binding to the ACE2 receptor by mutations. On the other hand, as I already said, they are less affected by the neutralizing activity of antibodies that are circulating. And several mutations occur, so that changes that make the virus more resistant to neutralizing antibodies may end up in less additional mutations to compensate for loss of binding, so that in the end you have a combination of several mutations that actually improve binding combined with reduced neutralization activity. And as a consequence, the efficacy of the vaccine will go down until a certain level where we would need revaccination with a different vaccine. So at the moment we have 4 variants of concern. The first one already rose very early after the start of the epidemic in January 2020 in China. So the first strain that actually spread over the world is not the strain that started in Wuhan, but there's already a mutation which has an enhanced transmission and a more efficient replication in comparison to the original mother strain. In September 2020 in the UK, the B117 was first reported with an increased affinity to the ACE2 receptor, with accompanied by enhanced transmission, more efficient replication, and an increase in host range. Some animals now could be more easily infected as well. And then in South Africa and Brazil, the mutation E484K arose, which with a compensatory mutation to compensate for the loss of binding, so that you have binding again, which also coded for escape of the antibody neutralization. And the Indian strain has many mutations, and these are just a number, which have a similar effect on better binding and reduction of neutralization. So what does that mean if you have a variant? What does that mean? The decrease in the fold decrease in neutralization in a certain variant. So the variants we have now, for example, the South African strain, has a decrease in fold binding between 5 and 10-fold. So if you have a vaccine that's already 95% effective against symptomatic infection, it would drop down to 10% in efficacy. So it really depends on the fold decrease of the variant, and again, it's not linear. I'm not sure what it means for the effective protection against severe infection, and whether this curve would also move towards the right, which means that you have also less protection against severe infection, but it is in line of reasoning that this would also occur. On the website nextstrain.org, you are able to look at the different variants that actually are circulating at the moment, and just a handful, but there are many more that have been sequenced already. And what you can do then is look at a specific country and look at the proportion of sequences that are reported over time. So to be clear, this is not all cases, because not everybody is being sequenced, but it's the number of sequences which fall into a defined variant group. And you may well recognize again the B117, which is over here, and recently the influx of the Indian strain, the B167, has been reported in some areas in the UK, and is actually a point of concern. And it's shown over here the sequences that have been reported in India. But you can look up for every country what has been sequenced in that particular country and which variants are at the moment most prevalent. Fortunately, 2 doses of vaccine, both of the mRNA and of the adenovirus vector platform, still provide a good protection against symptomatic disease for the B16172. So this is one of the reasons why the second dose now is moved to a shorter interval. Instead of 12 weeks, it's actually moving now to, I think, 8 weeks in the UK, because we want to be prepared if this strain, the B1617, is spreading more. Returning infected travelers may act as sentinels for variants of interest and variants of concern from areas of the world where there's no access to vaccine or genomic sequencing, for that matter. And most of Africa is in this unfortunate situation, where slowly now there are a number of countries where they starting to sequence the genome of the variants that are present over there, but for most of Africa we have no idea what is circulating. And this is an example of a variant of interest, the B162.0, which is originating from Cameroon, and the red closed circles indicate the moments of introduction into several countries where they have caused small clusters, and in Lithuania it has caused a larger outbreak. And so in the future, when people start to travel again, especially to the more exotic regions, where there is no access to genomic sequencing, they may come back and bring in a variant that has not been seen before, especially when that variant is less sensitive to the neutralizing antibodies that are present in the traveler after vaccination. Because the countries that, because there's still a large inequality in vaccine access globally, and especially the countries in the lower or in the middle and lower middle income countries, many of those countries have not started or are just starting vaccination campaigns. And the problem is that the more exotic tropical travel destinations are in those countries that are still struggling with their COVID vaccinations. So there is a real, I think it's really important, and it's also been promoted by the WHO, that we put emphasis on vaccinating as many people worldwide as possible to reduce the amount of circulation of virus, the introduction of new variants that then again would spread and cause new outbreaks. So if we take all that information together, we can try to formulate a kind of risk-based travel advice for an older traveler, and that's already somebody from 60 onwards, without necessarily any comorbidity. That is, and what type of information would you like to know? So you would like to make a kind of personal risk profile, looking at the age, comorbidities, whether that person had a previous SARS-CoV-2 infection and was boosted with one vaccine, or had received 1 or 2 doses of COVID vaccine, and what type of vaccine was used. We still do not have the possibility to determine neutralizing antibody levels, but I suspect that within the next 6 months there will be a kind of more practical proxy of protection we could use to determine how well where somebody is in his neutralizing antibody profile. Secondly, you would like to look at the epidemiological status of the destination. Is it an increasing incidence, or is it just a decreasing incidence of infection? What is the dominant circulating variant? Are the testing facilities available? What does the healthcare system look like? And what about the availability of oxygen in case of trouble? And personally, I would think that for this reason only, travel to high income countries, preferably I think within Europe, would still be something to consider, but I would be hesitant to make travel to areas where there is still little known about where the healthcare system is not that well developed. On the other hand, there are the requirements on entry and return. The European Union has issued a green card for those who have been vaccinated. And I still would say a green card means that's proof of vaccination. It is not proof of protection, and it's not proof that you are not infectious after vaccination. But people tend to forget that. But the requirements on return and entry may be different from country to country and from time to time. So PCR testing may be required before and after travel, and some countries will still issue quarantine afterwards. I would emphasize that we would still, even if somebody has been vaccinated, would still promote low-risk activities, go to areas where we can avoid crowding, wear masks where necessary, keep our distance, and wash our hands. So all the measures we were taking before vaccination are still valid afterwards, because there are still many variants that are circulating. We still do not know yet how well that you are protected. And finally, make up a personal health plan. Maybe we will have revaccination at the end of the year. For some of the travelers, it may be useful if they have a medical history to have a medical summary in case they need hospital care. find out what your emergency contacts are at the place of destination, have a good health insurance, and for the older people, what are the end-of-life care options if something really goes bad. And with that, I think we have a complete new, we are entering a complete new era where we are not only advising people on, for example, malaria, but we will have to advise travelers on COVID for the next few years to come. So to conclude, old age, already starting from 60, is one of the most important risk factors for severe COVID. After vaccination, incident cases still occur, most of them asymptomatic, but transmission is still possible. Neutralizing antibodies are the best proxy for protection and seem to wane more rapidly at older age, which may require revaccination depending on the speed of waning. But it could be after 150 to 250 days. Variants of concern reduce the efficacy of protection against symptomatic and probably also against severe infection. And the older traveler in the era of COVID-19 needs to be well prepared. Thank you for your attention.